Yep, my name's Alex. I'm a gastroenterologist, hepatologist from Hodge here. My accent, and I originally was not born here. So my journey really started just very briefly with the background. So I'm from Canada, Vancouver, the place where it's wet and cold and it rains more than it's sunny. But I've been here for about 20 years. So I trained in Sydney. My mom's Australian, my dad's from England, so I had the lovely three citizenship. So cheapest place to do medicine was Australia. So I trained in Sydney, and I went into gastroenterology because my dad has Crohn's disease. So that's something that I sort of grew up with, and I sort of always had an interest in it. But then in medical school, I discovered the liver, and I did some research in the store liver unit at Westmead Hospital with Jacob Cholangitis and Jeff Farrell, and that really got me really solidify my interest in liver disease, well, gastroenterology and liver disease particularly. So then I moved to Canberra, spent a couple of years there, comfortable and very, very relaxing. And then I moved to Melbourne, where I did my PhD in liver cirrhosis at Hodge. And then as I've sort of worked, I've developed an interest in overseeing sort of clinical trials of liver disease. And as you probably know, this condition, which is a very rare condition, as Carrie said, there's some interesting developments in trials coming up. And so that coincided with Carrie sort of organizing an inaugural PSC society meeting. So everything sort of came together. So here I am. So I'm hoping just to give you probably know more about PSC than I do. So what I was going to do is sort of a fairly interactive, you ask me a question, just stop me anytime, just if you don't understand something. It's a fairly sort of brief overview, but I can make it more detailed, less detailed, whatever you want. So I thought I'd first start by talking about PSC, and then I've also got a little talk with, because Carrie, you were interested in learning a little about liver enzymes.
Yeah, just a liver test and what the enzymes.
Yeah, so I've got a little bit of that as well. So I like to draw things when I talk, but Travis and I spend a bit of time getting this to work, so hopefully let me just see. So there we go. PSC. That's a very basic introduction. Now, 1867. Why is that important? Anyone know? So I know it because I'm from North America. It was really important thing that happened there. I wasn't born, of course, then, but so what was that?
Boston Tea Party?
No. It was north of Boston, west. So that's the check that the American government gave to Russia to purchase Alaska. You heard of the Alaska Purchase? No, maybe not. Anyways, so they bought it for $7.2 million. Okay, that's 2 cents for every acre. It was a bargain. And so I don't know how Russia cashed the check, but anyways, that is the check they used. That also happened to be where in Germany, the Dr. Hoffman first described a condition where he found in a patient where a bile duct, which is this right here, this is the common bile duct, you can see was thickened and called it sclerotic. And then he looked at the microscope and he saw disordered cells, and that was the first description of primary sclerosing cholangitis. Now, he didn't really realize it at the time, and it wasn't until the 1960s where there's a case series from 2 French physicians that really solidified it as a condition. So 1867. Yeah. So I want to talk a little bit about what PSC is, some of the associations, how you make a diagnosis, and how you can predict progression, what you do to sort of monitor, survey, and treatments, question mark. So what is it? Well, first, before we talk about the conditions, does anyone know what's bile? Does anyone know what bile is? What liver makes bile? Yeah, absolutely. So the bile, how much bile does the liver make? A liter, 2 liters, 4 liters in a day? 1 liter. Yeah, I think it's a liter. All the time it's making bile. So, if you look, these are bile ducts inside the liver. So it's constantly, these bile ducts are creating, because the cells in the bile ducts are actually creating bile, and it's flowing through these little tributaries, tiny little vessels, and bigger ones, until we get to the larger, common bile duct. Okay, there are two main liver cells, so it's pretty straightforward. Liver's easy. Two liver cells, the ones that are in the bile ducts, and they're called the cholangiocytes, right? And then the basic building block of the liver, which is the hepatocytes. That is the liver. Now there's some other things, stellate cells and stuff, but don't worry about those. So those are the two main liver cells. Okay? So the cholangiocytes are the ones that we're interested in today. Well, we're interested in all of them, but the cholangiocytes we're going to focus on. They're the ones that are involved in the bile. So you get about 1 liter of bile main, and it's constantly flowing. Okay? And you're right, it helps to absorb, digest food, and also used in waste elimination. Okay, that's important. So digestion and waste elimination. Okay? So that's really important to know. Now, so what happens in primary sclerosing cholangitis? Well, if you break down the word primary, okay, so it starts in the liver. It's not something outside the liver coming in. It's from the liver. Sclerosing, okay, so that's a inflammatory process. If you look up in Webster's dictionary, it's an inflammatory process that leads to fibrosis. Okay, so that's a primary liver inflammation process leading to fibrosis. I'll explain that in a moment. And cholangitis, so cholangiocytes, right? Those little bile duct cells. And itis just means inflammation. Okay, so anytime you see itis on the end of a medical word, it simply means inflammation. So hepa, that's the liver cells. Titis, inflammation. Diverticulitis, itis, inflammation. So itis just means inflammation. So you've got a liver disease, primarily starting in the liver, sclerosing, so inflammation leading to fibrosis in the cholangiocytes. So now fibrosis, another name we throw around is scarring. Okay, so what happens when you cut yourself? Like in fact, I cut myself with a peach knife on my wrist about 2 summers ago. It was a white peach. I like the demo peaches. Unfortunately, so it wasn't really worth it. But I got a scar out of it, and for the last 2 years, I've watched that scar. And scarring is just fibrosis. It's a healing process. It's just a normal thing that happens. So interesting. What happens in the liver here is that you get inflammation, okay, and then the normal healing process tries to get rid of the inflammation. In healing itself, it causes fibrosis. So it's actually a normal thing that happens, but it's happening in an abnormal way because the inflammation is constantly happening. So in the peach knife incident, the knife caused a little cut, right? And then took the knife away, and then the cut healed. There was scarring, fibrosis, but then over time it's slowly dissipated. And I've watched the last 2 years the scar slowly disappear. It's not completely gone, but it's much better than it was. But in the liver, the peach knife doesn't get removed. There's constant inflammation in the cholangiocytes, and the liver tries to constantly heal itself, laying down scar tissue. Never gets a break. That's the problem. There's no break. So you constantly get laying down more fibrosis, which leads to all the problems that we have in this condition. Okay. What else? So that's, in a nutshell, primary sclerosing cholangitis. Now, what happens in this scarring that occurs, this fibrosis, when you use the word scarring and fibrosis, it changes in the cholangiocytes, is you get, in fact it shows there, so you get stricturing and narrowing, right? So the fibrosis causes narrowing of these ducts, these tributaries. So back in Canada when I was growing up, you don't do that so much here, but there's all these streams we used to have in my house, and we used to build dams, right? And we used to build a dam, and then of course what would happen behind the dam is you get these huge pools forming, okay? And we used to throw rocks in little boats and try to catch frogs and stuff, but anyways, I digress. But in the liver, the same thing happens, right? So you get this dam or scarring, but of course the bile is trying to flow. Well, if you dam it off, what happens? You get this pool in the bile, right? So you get this narrowing and stricturing and fibrosis causing pooling of bile and back pressure in the liver, right? And it's that back pressure which eventually causes, because you're not getting rid of the toxins, right? Not getting rid of the stuff you're supposed to, can cause inflammation of the primary liver cells, right, which are the hepatocytes. Okay? And the hepatocytes, when they start getting injured, then things lead to, cirrhosis. You've heard that term? So we'll see hepatitis, inflammation of the hepatocytes, leading to fibrosis again because they get inflamed, but they can't, because inflammation doesn't stop. Fibrosis develops, and then you can get cirrhosis. So do you see how everything's intertwined? So you've got the cholangiocytes just minding their own business, but then something causes inflammation. That inflammation causes fibrosis. Fibrosis causes the blocking of the streams. The blocking of the streams causes back pressure. The back pressure causes inflammation in the hepatocytes. The hepatocytes get inflamed and they get fibrosis, and then you end up with what we call cirrhosis. So you see there's a knock-on effect. Okay? The other problem with back pressure is that you need the flowing. Okay, you need that flow in the stream. Because like in the stream, when I blocked it off and made a dam, that water became a bit stagnant. Okay? And just like in the bile system, if you get back pressure and stagnant bile, we'll call it, there's bacteria everywhere inside of us. And if you don't have a nice flow, you can get these stagnant areas, these small narrowing and pooling, which can get inflamed and infected, and that's called cholangitis, and bacterial cholangitis. And that's another complication that can occur. So any questions so far about that? Does that kind of make sense? Yeah?
In the diseased liver, is the bile of a different quality as a result of the fibrosis?
No, it's not. It's something that in the cholangiocytes that makes them susceptible to a normal bile. And then what that is, there's a lot of theories, but the bile itself is not changed. So, as I said, causes. So we don't really know what causes this. There's clearly a genetic component. There's a genetic component with all diseases. It's thought to be an autoimmune disease because it's associated with other autoimmune diseases. Environmental, well, again, a lot of conditions we have got some environmental components, so that makes sense. And then the microbiome, which is sort of the flavor du jour. It's sort of thought to be implicated in all sorts of conditions, everywhere from heart disease to fatty liver to rheumatoid arthritis to psoriatic arthritis to lupus to primary sclerosing cholangitis. So in this condition, what the microbiome, one of the theories is that, so what's always happening in the liver is you're actually getting this cycling of bile. So I don't know if you know, so when the liver produces bile, it goes into the intestinal tract, but there's actually a reabsorption of this back into the liver. You're getting this constant cycle. It's called the enterohepatic circulation. So of course, when that's happening, your intestinal tract is actually taking up bits of bacteria, whether it's bacterial cell wall or it's metabolites from the bacteria. So one of the theories is that there's some sort of alteration in the cholangiocytes' response to this bacteria that's coming up through the enterohepatic circulation. The other possibility is that maybe the gut bacteria itself is different. So maybe it's different. People with primary sclerosing cholangitis have a different microbiome than someone without the condition. So these are two theories that are sort of emerging. As I said, it's a very interesting field. There's a lot of conditions that may be influenced by changes in gut biome or how we respond to the gut biome that we have. And as Carrie pointed out, it's a rare disease, and there are all sorts of different data on this, and depending on the country you look at and reporting rates, it's somewhere between 1 and 5 people per 10,000. Now there's lots of different associations. So primary sclerosing cholangitis, as you know, is associated with inflammatory bowel disease. So they generally say that between 40 and 70% of people with PSC at some point will have or do have inflammatory bowel disease, and the majority of those, or 2/3, would be ulcerative colitis. Now, having said that, people with ulcerative colitis or Crohn's disease first, less than 8%, in fact it's probably a bit high, it's probably more like less than 4 or 5%, will go on to have primary sclerosing cholangitis. And often the diagnosis occurs before the diagnosis of inflammatory bowel disease. And as I mentioned, there's that autoimmune link, so 25% of people with primary sclerosing cholangitis may have some other form of autoimmune disease, whether it's thyroid, like Hashimoto's thyroiditis, rheumatoid arthritis, or even lupus, something along those lines. Now, cancers are the big thing that we all worry about. This isn't just primary sclerosing cholangitis, but let's be honest, everyone worries about cancer. That's the big thing we all care about, really. And there is a number of associated cancers with primary sclerosing cholangitis. So generally, it's thought that about 10% of people with primary sclerosing cholangitis at some point may develop a biliary cancer, and that's a cancer in the bile duct. And now gallbladder cancer is one that is less common. It's actually probably more like less than 2% of people who develop cancer in the gallbladder. And then there's a increased risk of colon cancer. Now, interestingly, I should probably just mention I just find this interesting, I mean, not, but in ulcerative colitis, there's a sort of a phenotypic variation of ulcerative colitis where people tend to have primary sclerosing cholangitis. So it tends to be people with more right-sided disease, somewhat on this side here, people with like ileitis but don't have Crohn's, and then get people who have rectal sparing. So it's sort of like a right-sided disease with a little bit in the small bowel and nothing in the rectum. And that tends to be the sort of flavor, that's a bad word, but sort of flavor of ulcerative colitis that is more associated with primary sclerosing cholangitis. And so why is there an increased risk of cancer? Again, it comes down to that whole irritation thing, right, where you're getting inflammation. So the cells are not happy. And so when the cells aren't happy, they're trying to heal themselves. They can be genetic changes, and they can, of course, those changes can lead to cancer. So that's another one, as I mentioned, about the static bile. That's bacterial cholangitis. So that's when the bile is just not flowing. You're getting scarring in the bile ducts. You're getting infection occurring in those little tributaries, and then we call that acute bacterial cholangitis. There's all sorts of different bacteria that can cause it because we're covered in bacteria. There's lots of bacteria inside of us, so there's no one particular bacteria that does it. The symptoms are often quite variable, so they can be just anything from pain, fever, no pain, fever, no fever, abnormal blood test. So it's quite variable. Generally, it's pain and fever, but not always. That's an important thing. So having bacterial cholangitis doesn't increase or doesn't portend a worse prognosis. So people who've got lots of problems with infection don't have worse prognosis for those who don't. Okay, so that's something to keep in mind. Bone disease, I'll just say very briefly, because bile, as you said, Matt, is used in absorption or digestion of things, a lot of fat-soluble vitamins, including vitamin D, can be impaired, and osteoporosis is one of the complications that can arise from sclerosing cholangitis. Then the next thing is symptoms. So the itch is really the big thing, and that's because of the bile salts that get deposited in the skin. So what's happening is, if you thinking of the stream analogy, right? So you've blocked off the stream, right? The bile stream. There's a dam. There's a big pool forming behind the dam. Well, in the liver, of course, like in my stream, the water sort of flowed onto the bank and somewhere else, right? Well, in the liver, that bile actually can get taken up into the blood, right? So there's actually, you've heard the word jaundice, you probably know what that is, and that's yellowing of the skin, the sclera of the eyes, and that's deposition of things from the bile in the skin, and that can lead to an itch, and that can be pretty not fun. And so there's a number of treatments people use called cholestyramine. That's kind of like a bile acid binder in the gut, and that's to reduce the amount of bile that's getting retaken up. Rifampicin changes the metabolism of the way bile is actually metabolized, and sertraline is like an antidepressant, which just helps. I'm not entirely sure the way that one works, but that helps with the itch. And then fatigue. Now fatigue is just lots of things cause fatigue, but in PSC, fatigue can be quite debilitating. That can be people with and without cirrhosis. So the natural history, so the top one here, so this one here is liver, this is IBD activity, and this is the progression of the liver disease. So you can see there's very little correlation between the progression of someone's inflammatory bowel disease and the progression of their liver disease. The two things seem to be disconnected, okay? The other thing is biochemistry, as you can see, of the liver disease typically fluctuates. Okay, so and I'll explain I'll talk a little bit more about that in a few slides on the track. But it's quite typical to have variations in liver enzymes. Okay, and I'll talk about liver enzymes later. But it doesn't seem to correspond with the activity of the actual inflammatory bowel disease. And as you can see. Erase these here. As you can see, there's all these fluctuations in the liver enzymes, right? But there's just a general movement from inflammation. Cholestasis means that static bile, okay? And as that inflammation gets worse, the liver tries to heal itself. You get fibrosis, and then of course, in its worst case, you get cirrhosis. Now, cirrhosis just means really bad fibrosis. It just means crappy fibrosis. Bad fibrosis, because once you have that much fibrosis, we give it another name because that amount of fibrosis, people can have all sorts of various complications. So we give it its own name, okay? And often there's this huge sort of lag time between when someone probably has the beginnings of PSC and when it actually gets diagnosed, because there are no symptoms initially. So you've got this huge preclinical time here, because the liver enzymes fluctuate. Your doctor may check them one month and they're normal, the other month they're abnormal. So what do you do with that? There's other things that can cause abnormal liver enzymes, right? So it's not just having some abnormal liver enzymes doesn't mean you've got PSC. So it's often difficult at the beginning to make the diagnosis. Now, of course, as you see here, right, when there's actual when there's the diagnosis made here, when there's actual fibrosis, okay, cholestasis, that's when generally the diagnosis is made. And then there's more than just liver enzymes, which are normal. Typically imaging, so whether it's an ultrasound, MRI, fibroscan, which we'll talk about later, typically something else will be abnormal. Okay? And then there's a number of years as the fibrosis can progress, and look, from fibrosis to cirrhosis and liver transplant, it's not an absolute definite, one equals the other, but generally it's a few decades, 2 decades between when there's diagnosis and when there's enough fibrosis and cirrhosis where someone would need a liver transplant. They say, when you look at medical textbooks, a typical person with PSC is a male in his 30s with IBD. But really, if you look at the studies, particularly the studies of clinical trials, who enroll patients with PSC, there's a huge range of people who present, all the way from young children all the way to elderly, well, not elderly, but older individuals. Now the liver tests, as I mentioned, they can be abnormal, and they typically are what we call a cholestatic picture. So I'll explain a little bit more about liver enzymes later, but basically, again, it's really straightforward. There are two main groups of liver enzymes, or liver tests. When you order liver tests, you get two main, and they come from different parts of the liver. One are from the, as you probably guessed, the cholangiocytes generally, and the other ones are from the hepatocytes. It's pretty easy. Liver test from so the abnormal liver enzymes from the cholangiocytes, abnormal liver enzymes from the hepatocytes. So at the beginning, when you've got inflamed cholangiocytes, you're going to have liver enzymes that are elevated from them, and that's what we call a cholestatic picture. And that generally, the main one is the ALP, that's the alkaline phosphatase. That's, if you remember any liver enzyme, that is really the most important one. That's given off by the cholangiocytes when they're unhappy. Bilirubin, that's part of the bile, it's in the bile. So if that's elevated, that's telling you that the liver, is spilling bile into the blood. The other liver enzymes, the ones from the hepatocytes, these guys, okay, which I'll talk about in the talk, they're given off, as I said, downstream once the liver itself starts becoming inflamed, or the actual hepatocytes becoming inflamed. So that's down the track when you see when there's hepatitis. So diagnosis, typically it's made with an MRI. Okay, and what you see in the MRI is you see these, where's the one here? Oh, here you go. So you can see here, so there's like, there's an area where there's nothing there, and then there's white. So that's basically narrowing or scarring, and then bile. So this whole little tree you see here this is the liver, and this is looking at the bile ducts. Okay, and you can see there's all these sort of irregular using the eye of faith, really, you sort of step back, you can kind of see that they're not smooth. They're a little bumpy, and you see there's little balls and little bumps in these areas, and that's just indicating that there's these little areas where it goes, and this there's a bit of scarring, and then a dilation, and that's kind of what you get, okay? Because there's little bits of scar tissue, and you get these little, like using my stream analogy, you get the little dams, and you get the buildup of bile, and that's kind of what it looks like in an MRI. You get this, they call it beading, and there's various other terms they use, but essentially, it's the MRI is probably the best tool to show these little bits of scarring in the bile duct and the dilated ducts. Again, that's just showing it again. You can see, if you just look at it, it doesn't look smooth. It's not smooth. It's wispy. It normally should be nice and smooth and nice white sort of tree, and it's just not that. So that's an MRI. That's looking for these scarring and blocking in the bile ducts. But what about the liver itself? What about the fibrosis in the liver? Okay, because and I'm talking about the hepatocytes. What about the hepatocyte fibrosis? Because that's what the progression of that is what leads to transplant, right? Because it's the function of the actual liver itself, the hepatocytes. As they get worse, it leads to cirrhosis and transplant. So how do you know how the liver itself is doing? Well, there's of course biopsy. The problem with biopsy in PSC is it's a bit patchy. It's not homogeneous. So we tend to use non-invasive tools, and one of them is called FibroScan. You may have had this. It's basically an ultrasound-like device, this thing right here, and it sends these little vibrations through your liver. Okay. And what happens in the liver that's got scarring, like scar tissue makes your liver hard. So as the vibration travels through the liver, the harder the liver, the faster the vibration travels. Okay, the softer the liver, nice wall, vibration travels nice and slow. So the harder the liver, the more scarring, more damage the liver has. Okay, and if there's lots of scarring, we call that cirrhosis. And so we use FibroScan or some other type of device like this to get some sense of how much liver damage there is. Now, so how do we monitor this? Well, the easiest thing to do is get a blood test. Now, but of course you're probably thinking, well, the blood test already told me fluctuating. Yeah, I know, but it's still the easiest thing to test, and you can pick up some of the, so as I mentioned, what fluctuates actually is the ALP. Remember I told you that's a really important blood test that comes off from the cholangiocytes? Well, that fluctuates, but if you start getting abnormalities in your other liver enzymes and your bilirubin starts going up, well, that's suggesting that your liver is progressing, okay? So we still do liver tests, and of course we review people, and we do MRIs and ultrasounds, not only to look at the scarring in the liver, but also to screen for the other things that I mentioned, the cancer in the bile ducts, cancer in the gallbladder, and we do FibroScan regularly, every 6 to 12 months, and that's usually to look to see if someone's progressing to cirrhosis. ERCP, that's an endoscopic procedure that clears bile ducts, so if people have these big strictures, you can actually have a procedure where there's a little catheter inserted into the bile tree and actually tries to unblock the strictures themselves. Any questions so far? Yes?
Sorry, you didn't mention the GGT, is that because it's not relevant?
It tends to go up with the ALP, but it's often not, the elevation in GGT is not very important because GGT is an enzyme which is also induced when the liver metabolizes things. So often people are on a various number of drugs and then the liver has to metabolize many of these drugs. So the GGT can be elevated not because there's a problem with the liver, but because of the drugs themselves. And so we don't tend to follow GGT too much. Any other questions? So treatments. Okay, well, I mean, that's a crapper. Currently, there are no pharmacological therapies shown to be reliable. Okay, so that obviously, I mean, we know that. That's not great. Ursulfolk, ursodeoxycholic acid. So many people are put on that. Well, why? Well, because frankly, we don't have a lot else. Okay, and it's really a low dose. But then if you look at the actual data, you know, it really wasn't great. The studies showing low dose actually made a difference at reducing ALP, small numbers. And in fact, they showed high dose, which is 25 milligrams per kilogram, actually led to more serious adverse events of death, transplantation, cirrhosis. So ursulfolk, may help at low doses, maybe, but small numbers in the study. Higher doses definitely don't help. So that's probably one thing a lot of people are on. Antibiotics. So antibiotics, well, why would people take antibiotics if they don't actually have an infection, right? Well, it's because it's based on that whole microbiome theory, right? So, and the microbiome theory and its effect on the cholangiocytes. So there's a small study, mainly it's vancomycin, 12 weeks, and there was a small decrease in the ALP. Again, what does that mean? But that's really, all there is at this stage. We've got a couple monoclonal antibodies, so Sclerosing, that's a drug often used for ulcerative colitis. That was trialed in PSC, didn't work. Simtuzumab, that's a medication specifically for liver fibrosis, and there was a trial, in fact, the biggest trial in PSC patients, simtuzumab, and that absolutely didn't work at all. But I will talk about that trial in a moment because some interesting things came out of that trial. Then that leads to some of the more newer treatments, and Sclerosing is a new class, is a member of a new class of drugs called FXR agonists. And in the phase 2 study, and what it's used for is so FXR agonists, they affect bile metabolism. Okay, so they change the bile. Sorry, I was not sure the name. Was it Sam? No. Anyways, you asked me about bile. So the FXR agonists do something to change the bile, and they seem to not only be helpful in this condition, which I'll talk about in a moment, but also other liver diseases. So this phase 2 study using Sclerosing for 12 weeks showed a decrease in all liver enzymes in patients with PSC and a change in bile salts. Okay, so it was only 12 weeks, but because of that, they've now moved into a phase 3 study for a lot longer, not just 12 weeks, but we're talking a couple of years, and they're going to be looking at, of course, fibrosis, complications, associated complications, liver enzymes. And that's the study that you probably have heard about that's taking place in various places around Australia. So that's very interesting. So that's probably the only at this stage the only promising drug in the pipeline, and so we'll be hoping to have people enrolled in that study soon. But as I mentioned, sorry, yeah.
Can you talk more about that trial?
No. Well, I mean. Yeah, I can answer any question you have about it, but I wasn't going to go through the trial itself.
What would be some of the conditions, or is it randomly get put on a list?
So it's 3, so yes, some people get placebo, you're right,
Yeah.
but the majority don't. So only a third will get placebo, the others won't. You can't have had cholangitis within 6 months. Can't have been started on an antibiotic within 6 months. You'll need a liver biopsy, despite the problems with biopsies, at the beginning and the end, and then a lot of monitoring, MRIs, fiber scans. In fact, they're actually using the fiber scan for the first time as a if you've got a fiber scan result, it's too high, you're actually excluded. So that's sort of and then then you're going to be taking a medication for a couple of years, and you're going to have a biopsy at the end, basically. But we've got, I think, you have some details. We like to keep that.
Yeah, we can. We've got information sheets if anyone's interested in having a look at the study. It's approved by our ethics and our governance. The only additional thing to that would be that people can't have cirrhosis of the liver.
Yeah.
So people who've got really advanced liver disease, unfortunately, they can't go into the study.
Yeah. So it's people without cirrhosis, without having had an infection in the last 6 months, who are willing to have biopsy and fiber scan. That's easy. So we can get some of that details out. And do we have do we know which hospitals are running it in Melbourne? I know we are, obviously.
You guys, Alfred,
Yeah.
Bridget, Austin.
St. Bayes, the Austin,
Yeah.
and the Alfred, yeah.
And then in Sydney, Jacob would be in Sydney.
I'm not sure on it. Travis sort of got any more info on that. I've been waiting to get the list. But
Yeah, Jacob wasn't there. I would have shot Westmead for sure.
Yeah.
Would have it.
So Kerry, I can find that out for you and give you details
Yeah.
of what other
So we've got a
sites
few-
across
Yeah,
Australia.
we've got a few interstate people on the group that
Yeah.
Yeah.
came to,
So,
so we can
yeah.
direct them to which hospital.
Yeah, so if you're interested in trials, probably best to look
They
through
can,
you.
they can come to me,
Yeah, talk to Carrie, and then she can put you in touch with someone. The problem with all these, not just PSC trials, but I mean any clinical trials, that often your treating doctor they won't know about it, and that's just because it's just not mainstream. So don't be surprised if you speak to a treating physician and they don't have any idea. That's just the reality of these trials. Because they're not approved drugs yet. Unless you're working sort of in the actual working on trials, you don't necessarily know these things exist. So don't be discouraged if you talk to your doctor and they've got absolutely no idea. Okay. So just talk to Carrie, and then. So I mentioned that the simtuzumab drug completely failed, didn't do anything, but it was very good for these 2 reasons. So it was a long study, it was 96 weeks. It was 234 patients. So that's if you look at PSC studies, it's a lot of people because it's a rare condition. And what they did find is 2 important things. Okay, number 1, ALP. So we used to think that you could follow ALP, and as it rose, or as it fell with so-called treatment, that would predict people's progression. But it actually didn't in this study. What it showed was how high your ALP was when they first brought you in the study was more predictive of what happened to you later on. And the higher that it was, the more chances you had clinical events. What are these clinical events I'm talking about? I'm talking about leading to cirrhosis, infections, cancers. Okay, so and they also found that the change in the ALP was actually not associated with the clinical events, which is a bit depressing. So those patients who had ALPs that were high, that were low at the end, didn't meet anything. In fact, the most important thing was how high was your ALP at the beginning of the study. Okay, so ALP in itself, this liver enzyme, may not be a good tool to determine whether a treatment is working. Okay. The other thing is they found that, and this makes sense, so if you got fibrosis, so it's not just scarring in the cholangiocytes, that's what the disease is, but scarring in the bulk of the liver, which are the hepatocytes. Okay, so if you got liver fibrosis and hepatocytes, that's bad news. We know that because, as I said to you, that's what happens, right? As you get more scarring and bile stasis and inflammation in the cholangiocytes, that leads to hepatocyte inflammation and scarring. All this did was confirm that when you have hepatocyte inflammation and scarring, that means your disease is progressing. Okay, again, that seems to be common sense. But they found that using a FibroScan, the cutoff, so when people need to be concerned, was that 8.7 value. It's just a number that you get when you do the test. Okay, and they found that anyone above that had a six-fold increased risk of having these clinical events. So where does that lead us now? Well, I mean, the good thing is, although this is a rare condition, things like, as Karen mentioned, we're putting together like-minded people. And it's really that when you've got something that is so, that occurs so infrequent, you never come across somebody with the same condition, as Karen said, you feel isolated. So it's really good now that we're starting to bring people together, and not only the patients, but the drug companies now, because there's maybe some treatments that are in the pipeline. There's a lot of people coming together now to really sort of bring people together to see if we can find some way for, whether it's better ways to predict progression, better treatments, better ways to monitor for complications. But that's where we're at now, and these trials facilitate that. And as I said, because of some of the early win in the phase 2 studies looking at these new class of drugs, there may be, hopefully in the future, some treatments that actually make a difference. So any questions about things so far?